So you mentioned POD24 before, which is obviously one of the major risk factors that unfortunately is unknown at presentation. So how do you approach a patient with POD24? So let's say they had our chemotherapy to start out with, and now they progress within 2 years. What is your go-to second-line regimen? I'm going to pick on Loretta first.
So I still would make a ploy for clinical trial in that setting because we really don't know, to be honest, and they're probably under-recognized. The idea behind POD24 is you take a disease where patients should live 20 plus years and you tease out those that are progressing sooner than you would expect to a pretty effective frontline approach. But we've not really understood the underlying biology that's driving that, so we don't have a great way of targeting that. What I'm most interested in right now is clearly epcoritamab in combination with R-squared because that data looks really good. But when I have the next phase 3 that rolls out that's positive, is my attention going to go then gravitate towards that? So I wish we had a better way to characterize the cells, the microenvironment, the patient milieu that's going to inform maybe a smarter approach to it.
So are there any biologic markers or tumor microenvironment features that you're familiar with that make a role in kind of how people select therapies? Or
well, I mean, the classic example is EZH2, but that was not a predicted biomarker for treatment effect. And so I think part of the challenge is we don't do enough biopsies in these patients. Many of them are treated in community setting, and I'm not saying that's right or wrong, but we probably don't characterize the microenvironment or the tumor as well as we do in a disease like large cell lymphoma that's a more life-threatening process.
And I think just to add to that, traditionally chemotherapy has performed really poorly with our POD24 patients, and the outcomes long-term are very dismal. And I think it's exciting that both bispecifics and CAR T-cell therapy, specifically in this population, which are high risk, have actually done really well with comparable outcomes in POD24 and not POD24 patients. So I think there's clearly something in the tumor microenvironment that the T-cell engaging therapies are impacting and changing the biology of the disease. And I think that's, especially in these high-risk patients, I tend to go for the novel T-cell engaging therapies, whether it's bispecific or CAR T compared to traditional chemotherapy.
So Jason, any role for transplant still in the POD24 patients?
Increasingly rare that we refer people for transplant now that we have so many novel therapies, and T-cell engagers and CAR T-cells have largely stepped into that role for the really bad follicular lymphoma, for those patients who have the disease that's behaving like large cell lymphoma, even though you biopsy it and it still says follicular. Having these novel therapies has, in my practice, changed the landscape so that I go to those more readily than I think about using transplant either as a primary therapy or as consolidation. It's been quite rare that I will do a transplant in that situation. I think the difficulty is knowing which patients require CAR T-cell or T-cell engager versus which patients might benefit from tafelen or from perhaps a bispecific plus R-squared versus R-squared. Which patients need the extra therapy for a triplet for a disease that either you live 20 years or you're in big trouble? It's a real challenge, as we've talked about, to really be able to identify those patients who are at the most need. Currently, we still fail to do that, as we've talked about.